What we're going to talk about today are the clinical and economic considerations for a medication-assisted treatment option. I just want to say a couple things before we start. We have a very rigorous slide deck to go through, and then we're going to have a panel discussion, and I'd rather we have time for the panel discussion. So if I speak quickly, I'm not hypomanic, I didn't have too much coffee, and it's not because I'm nervous, but I want to get through the deck. If I'm going too quickly, just someone slow me down. The other thing I wanted to say is, when we talk about medication-assisted treatment, if you take a look at the words, medication-assisted is the adjective, treatment is the noun. So that qualifies the fact that when we speak about MAT today, we're not talking about a silver bullet, but we're talking about something that's meant to augment psychosocial treatments. And there's a whole variety of them, but medication-assisted treatment is just to augment and to supplement and to give patients who have substance use disorders the same advantages that people have who have hypertension or other chronic illnesses. They're advised to make lifestyle changes, but they're also given medication to help them. So why don't we get started? We all know about the opioid epidemic. I think the salient features here are, facts are that there are estimated to be about 2 million people who have opioid use disorder, and as a result of it, we're going to emphasize economics, but remember, it's a question of losing lives, and it's every day, and I think they're estimating 66,000 deaths in the coming year from overdoses, and about 60 to 80% are reputed to be reported as being opioid related. The price tag is not just in human life, but it's also the cost that it's causing to the healthcare system. There's also the loss of productivity. Some opioid-dependent people, a treatment episode can cost $90,000 a year, and their average cost of care can be $90,000 a year. That's a lot of money to be paying for health care. Opioid use diagnoses went up nearly 500% among commercially insured members over 7 years. That's a huge rise in cost to the insurance companies, money they had to put out. And when we look later at the economic data, it will be from patients who did, in fact, have health insurance. Medication-assisted treatment is associated with fewer overdose deaths. It keeps people in treatment, which is a tremendous value, because if the patient leaves treatment because they're uncomfortable or craving, you don't have someone to treat. Decreased heroin use and, of course, reduced relapse. The sad fact, though, is that many people do not get medication-assisted treatment. And in another slide deck we have, I think it's only 1 in 3 patients with opioid dependence, opioid use disorder, actually receive treatment. So there's room to go in this. The National Quality Foundation, SAMHSA, and the President's Commission all have highlighted the importance of MAT for opioid use disorders. Unfortunately, although we've known that MAT is useful, the implementation and use of MAT has just not kept pace with the crisis. So we're somewhat behind the power curve on that. Another problem we have is in terms of barriers to being able to prescribe and use medication-assisted treatment. And I think everyone here can remember an occasion when you've had someone you wanted to start on a form of MAT, doesn't matter what, and they said, well, it'll take us 2 days to do the pre-certification. That can be a problem. The point being that when we deal with patients who have substance use disorders, sometimes you get someone where all the forces are acting on the patient, both internal and external, and you have that golden moment to get to them. And you can't say, well, hold that golden moment, and we'll fill out the pre-authorization papers, and we'll get them to you. You know, we don't like to act impulsively, but when you get that golden moment, it is the time to act. Now, currently, there are 3 types of medication-assisted treatment available for treating opioid use disorders. There's agonist therapy, and that's typically methadone. And all 3 of these modalities are involved with the mu opioid receptor. If I use a term you're not familiar with, please raise your hand and I'll be happy to explain it. So the mu opioid receptor is activated generally and results in dopamine release. So each of the MATs is meant to do something different in terms of minimizing the amount of dopamine that's released when people use substances of abuse. As far as methadone or agonist therapy goes, it's a Schedule II controlled substance, and it can only be provided at very regulated methadone treatment centers. And the number of those treatment centers over the last 30 years has not risen significantly. So those centers are not keeping up. The development of those centers is certainly not keeping up with the opioid epidemic. Administration is daily, and you do not have to detox someone before starting them on methadone. And again, as I said, the bottom line is none of these are silver bullets, all require counseling. Partial agonist therapy is typified by buprenorphine slash naloxone products, Suboxone, Bunavail. They are partial agonists, so they bind with the receptor, with the mu receptor, but they do not cause the same release of dopamine that you get with a full agonist medication. And there are some safety features that are built into buprenorphine in terms of less respiratory depression, but on the other hand, it's not as good an analgesic. It's available in pills and sublingual film. It's prescribed by a healthcare provider. A mid-level practitioner can now certify to get a buprenorphine waiver, or a physician. It's a Schedule III controlled substance. It does not require detox. To the contrary, you have to wait until someone goes into withdrawal before you administer a partial agonist. Again, counseling is required. And finally, antagonist therapy, which is typified by naltrexone, either naltrexone tablets or extended release naltrexone in the form of Vivitrol. It does bind to the opioid receptor, but when Vivitrol or naltrexone binds to the receptor, other opioids are unable to bind to that receptor. And I will show you a graphic representation of that. So the person who tries to use while they're taking Vivitrol or naltrexone is unlikely to get the effect that they're looking for. It's provided by a healthcare provider in form of an injection, and it's given every 28 days. So what are the indications for Vivitrol? And Vivitrol is one of several options to consider when treating patients with opioid use disorder. And there are certain slides here for compliance reasons with the pharmacode that I'm going to have to read, but I'll go through them quickly. So Vivitrol is indicated for the treatment of alcohol dependence in patients who are able to abstain from alcohol in an outpatient setting. Prior to initiation of treatment with Vivitrol, they should not be actively drinking at the time that they start Vivitrol. It's also indicated for the prevention of relapse into opioid dependence, meaning that the person has already been detoxed, and that's when you would administer it, because they have to be opioid-free, or you can precipitate withdrawal. And Vivitrol, again, bottom line, has to be part of a comprehensive psychosocial treatment program. Vivitrol is contraindicated naturally in patients who are currently receiving opioid analgesics, patients who have physiologic opioid dependence, meaning they haven't yet been detoxed. Someone who's in acute opioid withdrawal plays no role in detox, and people who have failed the naloxone challenge or have a positive drug screen. And how you do that depends on your particular agency to screen if someone is ready for Vivitrol, and anyone who's exhibited hypersensitivity to naltrexone, polyactide coglycolide, PLG, carboxymethylcellulose, or any of the other components of the diluent. So this is the model. This is the model that I spoke about before, and it's basically just a graphic representation of part of the brain. You have opioid receptors, and here they're, so if you have an opioid receptor that has Vivitrol, which is an antagonist sitting on it, that's the orange circles, then any opioid that comes along can't get onto it. And the Vivitrol binds to this receptor very strongly. It can be overridden, as we'll see in just a moment, but basically it also has some effect possibly on the effectiveness of endorphins, endogenous opioids. But the main thing is excessive stimulation of dopamine and the dopamine reward system is blocked. And that's really the common pathway here for all forms of use disorders and other pleasurable activities. Again, some warnings, vulnerability to opioid overdose. After someone's detoxed, patients are likely to have a reduced tolerance to opioids. Vivitrol blocks the effects of exogenous opioids for about 28 days. And as the blockade wanes and eventually dissipates, use of previously tolerated doses of opioids, in other words, what the patient was using before they went into treatment, can result in an overdose death and require a respiratory resuscitation or whatever it takes to bring them around, but it does result in it can result in a fatal overdose. And causes of opioid overdose with fatal outcomes have been reported in patients who have used opioids at the end of their dosing interval, meaning at day 28 or after, and or if they missed a dose and they disappeared for a while and they come back, they haven't had their follow-up visit for Vivitrol on day 28. Caregivers, the partners, the people who live with these people have to be instructed that this is a possibility. So not only do we have to inform our patients, but we also have to inform the people around them and hopefully get that message across. When you go to when you go to rehab for 28 days, you're also prone to the same phenomenon. Any attempt to overcome the Vivitrol blockade by taking opioids may lead to fatal overdose, and patients should be told of the serious consequences of trying to overcome the opioid blockade. It's not uncommon at the beginning of treatment for people to try using an opioid after the Vivitrol is injected, but to try excessively and to use larger and larger quantities of opioids can have a bad outcome. Of course, we're talking about an injectable medication, so injection site reactions are a possibility, and they're usually characterized by pain, tenderness, and induration, which means it gets a little bit hard. Injection sites that do not improve, in other words, the pain, the swelling gets worse, they have to seek immediate medical care. And one thing that does increase the likelihood of a injection site reaction is a subcutaneous injection. Are there any nurses here? So a nurse will tell you that the way to give an injection is a deep intramuscular injection. That's the way it's supposed to be given. People who are not experienced in giving injections, they kind of slide it along the surface and give a subcutaneous injection, and that's the kind of injection that usually results in a bad, not a great outcome. We have needles supplied with the product. Those are the only needles that should be used. There are needles to draw up the product, and there are needles to use based on the patient's side to administer Vivitrol. And again, patients should be informed, hey, if your injection site reaction persists, contact your healthcare provider. Precipitated opioid withdrawal, which means administering an opioid antagonist to an opioid-dependent patient. When you have the opioid receptor that I showed you before, those green cup-like structures, and there's an opioid on it, Vivitrol comes as an antagonist and knocks it off. And that causes something known as precipitated withdrawal. And precipitated withdrawal can be severe. It has enough physiological changes that it may result in the need for hospitalization and sometimes even the ICU. So you have to establish with your client that they are drug-free, and based on the protocols of your individual institution, either they can pass an naloxone challenge test or they have a negative urine. The most important thing is to look them straight in the eye and say, I want to help you. I don't want to cause you any discomfort or harm. Tell me, did you use? Just look them in the eye and say, even one is going to cause you problems if you've had it in the last 7 to 10 days. Trust is the basis of that relationship. We recommend, the package insert recommends a 7 to 10 day period free of opioids before administering Vivitrol. So someone coming out of detox, you start counting the day after detox. So if they're in detox for 5 days, day 6 is the first of the 7 days that they have to be opioid free. Okay. I want to just remind you, you have the package inserts, everyone. So anything that I didn't specifically speak about here, you can read at the package insert. And everyone who's using Vivitrol or it's being used in your institution or facility, please take an insert and you can get all the information you need out of there. And we also have medical science liaisons if you have further questions. So Alchemies will provide you with all the information you need regarding Vivitrol from people who are qualified and competent to give it. There is also the risk of hepatotoxicity, in other words, elevated liver enzymes. Alcohol and opioid-dependent patients who take Vivitrol have to be monitored for the development of either suicidal ideation or depression. And the bottom line is your patients will say, well, what if I'm in a car accident and I'm blocked from using opioids? So using potent opioids, a person who's qualified to do so, an anesthesiologist or an intensivist, can override the blockade in an environment where they're capable of supporting the respiratory system and circulatory system. So no one has to worry that they will suffer. And of course, there are other means for providing analgesia in the perioperative period. These are some of the other things you have to warn people about, including hypersensitivity reactions, injection site reactions, but also if you have people on anticoagulants, because if you hit a vein by accident, you'll wind up with a hematoma. And again, Vivitrol does not have a role in treating alcohol withdrawal, just as it does not have any role, for sure, in treating opioid withdrawal. Other adverse reactions. Okay, so there's 2 sets of adverse reactions here. The adverse reactions most frequently seen in the study that led to the approval of Vivitrol for alcoholism included nausea, vomiting, injection site reactions, muscle cramps, etc. The adverse events that were seen in the Vivitrol study in 2010 that led to the approval of Vivitrol for opioid use were hepatic enzyme elevations, injection site pain, nasopharyngitis, and insomnia. Now, the study that led to the approval of Vivitrol for the treatment of opioid dependence, remember we received approval for the treatment of alcohol use. Well, it was alcohol dependence back then. Everyone using the DSM-5 here, by the way? Okay, so I'll just use that term, but this was based on people who were opioid dependent. It was a 6-month double-blinded trial of monthly injections, and participants were screened after completion of detox. Remember, you can't use Vivitrol in a patient who has opioids on board. They have to be detoxed, and you need the 7 to 10 day interval being opioid-free. They had to abstain for 7 days prior to treatment, and they were randomized into 2 groups. One group got Vivitrol and psychosocial counseling, and one group got the placebo injection and psychosocial counseling. Never administered without the element of psychosocial counseling. So what we found was that patients treated with Vivitrol and counseling had higher rates of complete abstinence. 23% were completely abstinent of those who got the placebo injection, and 36% who received Vivitrol. So the numbers, I think, speak for themselves. On the other hand, if you look at how many totally, what percentage of the weeks of the study people were totally free of opioids, that there weren't any uses at all, as documented by self-report and urine toxicology, you find that only 35% among the placebo patients, 90% with the Vivitrol patients. And the way it reads is the median placebo patients. So it's hard to talk about a median patient, but this is what the data shows. Very important is one thing that we didn't have in the DSM-4 that we do have in the DSM-5 is the issue of craving. So this is a craving scale. It should, a craving scale usually goes from 0 to 100, where 0 is no craving and 100 is very much so. So if we look at patients who were on the placebo, and they both started out with approximately the same craving scores, 18.2 and 21.8, you'll see that at the end of the study, the patients who were on the placebo had a slight increase in their craving score. The patients in the Vivitrol arm had a slow and gradual decrease in their craving score, and that was down 10.1 points on the craving scale, which was actually a 55% decrease in self-reported cravings. And cravings is something that causes people to relapse. So if we're able to help them, I think that's a good thing in terms of treatment. Adverse reactions, again, adverse reactions are the ones, these are the adverse reactions we saw in the Vivitrol group compared to the placebo group, and the ones of note are the elevated liver function tests, the nasopharyngitis, the insomnia, injection site pain, and toothache. Now, one of the things that always comes up when you're using a new medication is, how does this medication compare to X, Y, or Z? So up until now, we haven't had anything that would compare Vivitrol to buprenorphine products. And you know that if you look at other medications like antipsychotics, it's the same thing. You don't have a comparative study, you just have to look at this data and that data and kind of make up your mind. Here's a study, though. It's called the XBOT study, and this study, and the X stands for naltrexone, BOT is buprenorphine outpatient treatment. If you look at this, this was a 24-week study. It was an open-label study. People knew what they were getting. How did they know? Because some people got an injection, some people got a film or a tablet. And it was conducted across a varied number of treatment centers, randomized to either naltrexone in the form of Vivitrol extended release, or to a buprenorphine naloxone treatment. And there were two. So as someone was screened, okay, there was the group of people who were screened able to go into the program, but when you got someone who was screened to go into the naltrexone arm, they had to wait 7 days to be opioid-free before they could get their Vivitrol. And during that period, the number of patients who remained in the study dropped from 283 to 204. On the other hand, people who were getting buprenorphine, there was a much lower dropout rate. And it's that waiting period that was the issue. And that's something that we acknowledge is an issue to be dealt with Vivitrol. What were the results of the study? Well, time to relapse was one of the primary outcomes that we were looking at. And let me just take a look here. Okay, so opioid relapse, if you look at all the patients who were screened into the study, was 65% among the naltrexone patients, 57% among the buprenorphine patients. And that's probably because there was that week of waiting before treatment could be started. But if you look at only the patients who received Vivitrol versus the patients who received buprenorphine, then the relapse rate was kind of similar, 52% versus 56%. It's that week again that was the issue. And again, this is an opioid cravings scale. In this case, however, the buprenorphine is the brown scale on top, and the Vivitrol group is the one on the bottom. And you can see that they both declined over time, came together, and leveled out as you got to about, I think, week 8. It's considered that they're coming together and leveling out. So it shows that both of the medications, both Vivitrol and buprenorphine, can reduce cravings. Again, the side effects we've spoken about, no major difference between the side effect profiles seen with buprenorphine and Vivitrol. There were 5 fatalities in the entire study. 2 of the patients were receiving Vivitrol, 3 were receiving buprenorphine, and they were attributed to be, 2 from Vivitrol, 3 from buprenorphine, and they were attributed to overdoses, which is becoming more and more common, unfortunately. There were limitations to this study. There was no control over the way that medications were administered. Each site used their regular standard practice. And we know that extended release naltrexone in the form of Vivitrol is somewhat of an issue. But it does reflect real-world circumstances because it wasn't as controlled as most studies, and it does have the potential for being generalized to a larger population. Okay, and again, in the head-to-head study, and this is unique, you had a reduction of 3.2 days in the use of heroin using, I can't see the color. It's the, with Vivitrol, 2.7 days less with buprenorphine. The authors of the Xbox study reported the findings of the 2 studies were consistent. Both studies found that for participants who were able to begin treatment, extended release naltrexone and buprenorphine were equally safe and effective in preventing relapse. And this is now we're going into economics for a moment. This is a retrospective study that was conducted by, I think it was actually Blue Cross Blue Shield. And it looked at the healthcare costs for people before they started the study, and for 1 year, and 1 year after. It was an insured population, which has to be kept in mind, and the different forms of MAT that they received were Vivitrol antagonist therapy, partial agonist therapy, which is buprenorphine, and methadone. And then there was also a group of people that went without receiving medication-assisted treatment. They looked at the claims over a 3-year period, and the index date, so the date that constituted the time that the study started, the baseline was the year before, treatment starts, and then you look at the next year. And let's see what the numbers showed. So if you take a look here, this chart, this graph, says that over the course of that 2-year period, patients who were receiving Vivitrol had a 5% increase in their total health expenditures, mean healthcare costs. That includes everything that they were getting, but it certainly includes emergency room visits, stays in rehabs, stays in psych facilities, and primary care or outpatient visits. It was 43%, there was a 43% increase, however, for patients who were receiving buprenorphine, and a 48% in those receiving methadone. And those who received no treatment, 39%. So the interesting thing on this slide is to take a look at where were there major changes. So in the patients, the gold bar, who received Vivitrol, there was a 42% reduction in inpatient cost, and that's a savings. With those with buprenorphine had a 9% decrease, and in the others there was a slight increase in inpatient cost. When you look at emergency room visits, ED cost, a 28% reduction in the cost of visits to patients from patients who were receiving Vivitrol, and an 11% reduction in patients who were receiving buprenorphine. The other two speak for themselves. What did go up, even with Vivitrol, were outpatient visits, and that's something that we consider a desirable outcome. Once we get people into recovery or into treatment, we want them visiting primary care physicians, be they family practitioners, internists, or psychiatrists, and that the fact that they're taking care of themselves. Outpatient, so outpatient cost is here. Pharmacy cost went up. Vivitrol does cost more money than buprenorphine or methadone. So we did see that go up, and patients in the Vivitrol group had the greatest percentage decrease from baseline in ER and inpatient utilization and costs, despite having more comorbidities and higher baseline costs. So it just turns out in this study that many of the Vivitrol patients had more psychiatric comorbidities: depression, bipolar disorder, anxiety. And this was not a, again, it was retrospective, and there was no control groups, so this is what you wound up with. In summary, we're dealing with an emergency. MAT is recognized as an effective treatment approach, but most patients are not able to access it. That's a problem. Vivitrol is an opioid antagonist option, and its indication is to prevent relapse into opioid use. You must be detoxed before Vivitrol can be given, and based on the study that we saw, Vivitrol has been found to be as equally safe and efficacious as buprenorphine once initiated, and there may be some economic value in the use of Vivitrol. So those are the slides. We'll stop here, and we'll hold questions, and I'm going to invite the panel up. So, gentlemen. And again, I apologize for the speed and the reading that we had to go through, but it was the only way to get through the required deck. So our speakers today are Dwight Warder from Michigan, from Detroit, who is the CEO of Self-Help Addiction Rehabilitation, SHAR. And we also have Ray Tomasi, who is the president of the Gosnold on Cape Cod. Is it a company?
Yeah, it's a company.
It's a okay. It didn't say what kind of company it was. I didn't want to give you problems. Okay. So we have a few questions that I would like to ask you. Let me get them out. Okay. So, Dwight, here's a question for you. How is medication-assisted treatment used at your organization?
We have a detox residential and outpatient program. Most people get started while they're in detox and in residential. So that's how we basically use it. Many people that refused initially to take it, later on came back and said they wanted it if they went out and relapsed. So that's how it's used.
Okay. And what have been some of the challenges you've had in your programs in terms of implementing the use of Vivitrol?
Well, SHARE historically is a drug-free treatment program, like many programs, doing mainly counseling, be it the whole spectrum of counseling. Being a drug-free treatment program and addiction over the years has always been thought as a disease that you treat without medication. As a result, also in our environment, most of our staff are also in recovery. Myself, I'm in long-term recovery. I've been clean for 34 years. Next month, it'll be 34 years. And most of our staff also, they're in long-term recovery. And there's a mindset that this is the way it must be because this is the way it happened to me. So many of our staff were against any kind of medication being given. Likewise, many of our clients have been treated time and time and time again, and they have been taught also the same thing, not to take any kind of medications. So we had to do a lot of education to overcome that.
Well, that's interesting. Thank you for that. I will just add, when I showed up at Bergen Regional Medical Center in 2010, there was no Vivitrol being used. There was no buprenorphine. Medication-assisted treatment was not happening. The most difficult part of the process was to educate and bring the staff on board, starting with the administration, then with management, line management, and then actually the line workers and get them involved. But once they came on board and saw what they could do with these medications, they bought into it, and then it became the way of doing business on a day-to-day basis.
Correct.
Okay, let's see what we have for Ray. Okay, so Ray, how is medication used at your organization?
Well, same. I mean, we have a fairly robust continuum of care all the way, starting with acute care and all the way through ambulatory treatments in a number of clinics and step-down inpatient units. So basically, medication is offered at every one of these treatment venues. And, our objective is really to encourage people to use them. We're trying to learn how to better match patients to the medication. If patients who stay with us in an inpatient setting long enough, of course, are started on the medication while they're in that setting, then we have, of course, the ambulatory sites where both medication, counseling, psychiatric service, mental health service, all of those things are offered in one setting. So it's about really sort of integrating this approach or this treatment option into all levels of care, and that has, that has had its challenges over the years.
So what you just mentioned, all levels of care, integration of levels of care, and seamless transition, as seamless as possible from one level to another, really ensures that patients will get what they need, and you're able in that way to see that they continue with their sobriety. Too often there are breaks in treatment, both with medication-assisted treatment for substance use disorders, but for other mental health disorders as well. So when you can put it all together, it seems to work better. What are some of the challenges that have come up in terms of implementing it?
Well, I mean, the challenges are, as you mentioned. I mean, there were some logistical challenges with prior authorizations and things of that sort, but that's pretty much been eliminated in Massachusetts. We no longer have that challenge. The biggest challenge to this is the reluctance of not just practicing clinicians, but I think the field to adopting the use of medication in the treatment of these disorders. We had that challenge with our own clinicians, and because there's sort of the historical context of what most of addiction treatment, how most of addiction treatment exists, and it comes out of a mentality that was sort of had a certain antipathy to medications and to, to psychiatrists and to medicine generally. And so this field was developed sort of as its own sort of sideline field apart from general medical care, and much of it through sort of 12-step philosophy, since that was the best and the only remedy at the time. And so that there are vestiges of that. And it's been very difficult to sort of unseat that as a primary and a unitary position about how you do treatment. It takes education, but education only goes so far, education and training. So you need to have champions who continue to push the issue, and then you have sort of demonstrated evidence, and ultimately you have patient feedback. So when patients talk about how these medications have actually helped them stay in recovery, eventually that begins to convert folks. But we still have not gotten to the place where the field has adopted these medications sufficiently to help more patients. It's a continuing challenge.
Regarding doctors, by the way, Doctors Bob and Silkworth forgive you. What are some of the concerns that have kept organization, well, actually, so in your case, other than the education, what other techniques have you used to get people on board?
Autocracy.
Okay, so it comes from top down. Okay.
Well, there's always the what I call the illusion of power in the office of the CEO. You can dictate certain things, and but you need to set the standard, and you need to drive innovation and ideas into a field that has historically been very set in its ways, and I think that part of the reason that's the case is because the field lacks clear standards. There's variability about what actually is an outcome. The way we talk about addiction and different aspects of addiction is different than the way you do in a medical field. So I think as the field gets closer to medical care, as opposed to a social service or a human service, I think then there's an expectation in medicine that medications, that standards, that protocols matter. I think you'll begin to see this field moving toward a much clearer path toward how you treat patients and how you treat them over the long term. Because as you pointed out earlier, most of what exists in treatment has been done in silos. So the idea of a unified, singular experience for a patient across levels of care has really not been there. And I think as we start to think more about how to deal with this as a chronic condition and look beyond an episode of care in a rehab or a detox or a sober living place or whatever, I think then that has to penetrate deeper into the field so that we think about treatment over the long haul to help patients manage their illness for life, not just for a brief period in a rehab.
So when you talk about a medical model, that's exactly what someone would be doing if they were treating a diabetic or a hypertensive. You're making lifestyle changes as well as, just not going to meetings and getting medication-assisted treatment. But there are important lifestyle changes that help the patient maintain that. Dwight, did you have anything else to add in terms of how you overcame some of the challenges in your organization?
I really agree strongly with what Ray has said already, but it's the same thing. It's also talking to family members. During visits, we've had little flyers and short conversations with family members about that. So often, as you know, clients come and you have to leverage their motivation. And very often their loved ones are very important supporters for that. So we work hard with the family members also to tell them about what Vivitrol is and the benefits of medication-assisted treatment to help them also. So you're getting everybody on the same page and speaking the same message. That also has helped also an outpatient. That family members, once they get involved, will also make sure they come for their injection every 28 days or so.
So I think that getting families involved is incredibly important because many of the patients or clients that we treat are still living at home, and their greatest champions are often their families. So that's a critical point, and getting the literature to them, the information, helps them feel better about what's going on.
True.
Either of you have anything that you'd like to add?
I just want to say that one of the things I think that would help in adoption is sort of a more expansive discussion about what you brought up very early in this presentation. That is that none of these medications are in and of themselves the sole solution, and that they're all designed and they're all intended to be used in conjunction with other psychosocial interventions and the kinds of things that historically we have done to help patients. And I think one of the things that would help higher adoption rates is talking a little bit more about the place of medications in a toolbox of recovery assets. There's been a little bit too much, I think, of sort of ideological positions taken around some things. People who don't want to use any medication, people who only want to use medication, and it's foolish, you know. I mean, I always remember a friend of mine who ran a medical center down here, and whenever something new came out, I'd call him and I'd say, Rich, what do you think about this new medication? And he said to me, he said, Ray, hurry up and use the new medication while it still works. Because many of these things come out and the promise is. But as you know, we see in the results of the XBOT study particularly, that they both have efficacy, but they have greatest efficacy when they're used in conjunction with other assets. And one of those is sort of recovery support and 12-step programs. And I think 12-step programs have been unreasonably sort of hit on, if you will, for not being open to other things. But I think it goes both ways. We need to continue to have great respect for the things that have worked for many people for many years and incorporate them into the way we present these things to patients. It's perplexing to me, and I'm sure, I know it is to all of us, that why do you have only a third uptake of medications when you have demonstrated research that these things help? They don't solve, but they help. And we don't have good translation of research and science into practice in this field. And I think that's something that changes when you get closer to medical care. And so I think the future is promising, but we got a ways to go.
I think when you go to the medical model, you have people much more receptive to trying what adds promise to treatment. If you go and you talk to residents who are training in nephrology or rheumatology, they're looking for the next medication, and they're not hesitant to use it. I think in psychiatry, as a psychiatrist, although an addiction psychiatrist, psychiatrists are sometimes very conservative in terms of introducing new medications. So I think there's inertia on this side of the 12-step recovery communities, but I think there's also some inertia within the medical communities and within institutions. So I think we've heard a little bit about how to start to overcome those.
But what changes that, and I think what's going to change that a little bit, is that you now have people in residency and medical school who have very close to them or know someone close to them who has died of an overdose, who has been directly affected by the opioid crisis. And I think that personal experience of those up-and-coming physicians is going to start to change the way they think about addicted individuals and addiction as a disease. And so it does, you know, in a kind of perverse sort of way, the epidemic is reducing stigma about addiction. And I think that has also some promise for the future.
Dwight, anything to add?
I was thinking about the same thing, but also with recovery coaches, there's many pathways to recovery. Before, people talk about 12 steps, make meetings, make meetings, make meetings. There's many pathways of recovery. Years ago, there were no recovery coaches, and many counselors were resistant to having recovery coaches, like they was infringing on their territory. It was like a turf war. Now they receive the recovery coaches. The recovery coaches are more informed also, and they know about medication-assisted treatment. So as time goes on, it will evolve. But addiction has mutated so quickly as a disease, as a condition. You know, whereas before, a lot of the opiate drugs, the codeine, things of that nature, people looked at those drugs and they used those, the heroin addict used those secondary to the heroin, they couldn't get it. Now you meet people who's using all the opiates early on at a younger age.
So That's true, and what you said about using recovery coaches, in New Jersey, we have people who will show up at the emergency room when there's an overdose and someone has to be reversed with Narcan, and then they will help get that patient immediately into treatment. There's a central line that they can call, find a treatment center that has an open bed. Because remember, when you reverse somebody from an opioid withdrawal, from an opioid overdose, you've now created someone who is in opioid withdrawal, and you have to have a way to deal with that. The best way is to get them into a treatment center. So we have a few minutes, and maybe we can take a couple of questions.
So I'm interested in distribution of Vivitrol being prescribed at your agencies versus, say, Suboxone, and then how that decision is made by the prescribers. Just because the efficacy was very close when we were looking at the studies.
There isn't really, we don't really have a great way of sort of using predictive modeling to say we think that you might be better on one medication than another. You might do better on one medication than the other. We're trying to learn how to do that a little bit better. So we've taken an approach where we would prefer injectable naltrexone as a first-line medication unless it's contraindicated. You know, it's given it once a month. There are certain things that make it a little bit easier. But patients that don't do well on it, we would discuss with them the option of transferring to buprenorphine. We have some patients who are on buprenorphine who are doing okay. If they falter, we might consider looking at the injectable naltrexone. In some cases, patients are stating a preference. So we have patients who come into the detox saying, I don't want to detox with buprenorphine. I want to do the alternative protocol, which would be a clonidine and comfort med protocol, because I want to get on Vivitrol because my friend Joe's on it and he's doing well. So it's very inexact right now, but I think that's an opportunity for us to really become more sort of driven by patient profile or by data to make better informed decisions about how to match patients.
So, of course, there are differences in the medication. The one thing I would say is, not one size doesn't fit all, and that all of these three are good medications. What you can say is that a medication may be better for one patient, a given patient, at a given time in their recovery. And as Ray said, I think over time profiles will emerge as to which medication is best for which type of patient.
See, the best thing about all of this, and the best thing about the increased interest of even, other pharma really, is that you now, and the possibility of greater investment in research and science, is that you have the potential down the road, the next 5 to 8 to 10 years to have other medications, better medications. This is all good for treatment and for recovery and for individuals who have this disease.
Are we out of time? Okay, so I want to thank everybody for coming. And the one thing I'd ask, please take the package insert that's on your chair. And if you personally are not going to use it, please pass it to the person in your organization who does. And again, thanks for coming.